Hi team, my name is Jessica Roberts. We've all been assigned to talk about the Child and Adolescent Trial for Cardiovascular Health, so this is my presentation on what I got from the report. Cardiovascular disease, or CVD, has been the leading cause of death in the United States for over 90 years. 28 states have cardiovascular disease as the number one cause of death, with all remaining states listing it as the second leading cause of death. Cardiovascular disease has multiple risk factors and has continued to increase, along with other health problems such as diabetes and obesity. Multiple public health trials have aimed at decreasing heart disease, focusing on some of the factors that contribute to the development of cardiovascular disease, including smoking, lack of physical activity, increased caloric intake, increased fat intake, and high serum cholesterol levels. This chart is showing where cardiovascular disease is most prevalent. The Child and Adolescent Trial for Cardiovascular Health, or CATCH, began in 1991 to attempt to make changes that would help children learn healthier behaviors before habits were formed. The study started with a group of children who were entering third grade and followed them until they finished fifth grade. The objective of the study was to assess the outcomes of health behavior interventions, focusing on the elementary school environment, classroom curricula, and home programs for the primary prevention of cardiovascular disease. This program had a control group as well as two intervention groups. The purpose of this type of design was to see which intervention made the most difference, or if any intervention made a significant difference. While no specific theories were mentioned in the write-up, much of the thinking in this study relate to the social ecological theory. The premise of the social ecological theory is individual behavior is based on the interaction with the levels of society around people. The CATCH study looked to affect the behaviors of an individual by looking at both the interpersonal level of family as well as the organizational level of school. By focusing on these systems, they hoped to encourage a wide group of students to change their behaviors. They believed that schools would be an ideal site for prevention programs. The design of the study centered around elementary schools near 4 different field centers in 4 different states who were participating in the study. These 4 field centers are listed here and are the University of California at San Diego La Jolla, University of Texas at Houston, Tulane University School of Public Health and Tropical Medicine in New Orleans, and the New England Research Institute in Watertown, Massachusetts. This allowed the study to represent various locations around the United States. The National Heart, Lung, and Blood Institute was also a major supporter of the project. The schools were based on the location near the New England Research Institute. Schools were selected by distance to the centers, ethnic diversity, the potential for the food service to be part of the intervention, willingness to have 90 minutes of physical education per week, agreeable to participating in a 3-year study, and willingness to be assigned intervention based on randomization. Following this study selection, 5,106 children who began in 3rd grade were selected to participate from 96 schools in 12 districts. These children were children whose parents allowed a blood assessment to be performed, and they consisted of the primary cohort for the study. 56 schools were assigned as intervention schools, or 14 per field center, and 40 schools were assigned as control schools, which were 10 per field center. Of the intervention schools, 28 schools, or 7 per field center, were assigned school-based interventions, and 28 schools, also 7 per field center, were assigned school-based intervention with additional family intervention. If children moved from the schools during the 3-year study, they were tracked within a 100-mile radius for follow-up. The school-based intervention focused on interventions in food service, physical education or PE class, and classroom curriculum. If the school was assigned to the school-based plus family intervention group, Worksheets were developed to be taken home by the student, and the schools held family fun nights for the parents and families of students. The study researchers expected to see changes in fat and sodium content of food, moderate to vigorous activity in PE, and serum cholesterol. They hypothesized that secondary endpoints would include psychosocial changes, total fat and sodium intake of the children, time engaged in physical activity, and blood pressure. Classroom interventions included classes aimed at eating habits for grade 3 through 5, physical activity for grade 4 and 5, and cigarette use for grade 5. Third grade classes had 15 lessons over 5 weeks. Fourth grade had 24 lessons over 12 weeks, and fifth grade had 16 lessons over 8 weeks. Each lesson was between 30 and 40 minutes in length. Teachers attended to 1 or 1.5 day training at the beginning of the school year to learn how to teach these lessons. The study also tried to standardize the lessons between schools and teachers. The food service intervention, known as Eat Smart, focused on the nutrients provided in school meals. Total fat was to be no more than 30% of calories, saturated fat no more than 10% of calories, and sodium was to range between 600 and 1,000 milligrams per serving. Food service employees attended a 1-day training at the beginning of the school year. Monthly follow-ups were also performed to help ensure needed information and planning tools were available to the food service. The aim of the physical education intervention was to increase moderate to vigorous physical activity to 40% of class time, as well as to make the activity enjoyable for the kids. These teachers attended a 1 or 1.5 day training at the beginning of each school year. Home interventions included a total of 19 packets split between the 3 school years. These packets related to the material being taught in the classroom to help reinforce the ideas as well as to get parental involvement. Teachers hung scorecards in the classrooms to encourage participation of the students. In 3rd and 4th grade, family fun nights were hosted by the schools and included dance performance by the students, food booths with healthy snacks, healthy recipe distribution, and games for the families. To understand how well the interventions were being followed, multiple interventions and analysis tools were used. Multiple individual levels were gathered through testing and measures. A health behavior questionnaire, or HBQ, was given at baseline in the spring of 3rd and 4th grade and at follow-up. 30 students from each school were selected to complete a 24-hour recall of what food they had eaten at baseline and follow-up. This 24-hour recall was analyzed using the Nutrition Coding Center database. 5,000 plus students who agreed to give blood samples gave non-fasting blood samples to determine lipid levels at baseline and at follow-up. Students had their blood pressure taken at baseline and follow-up, having their blood pressure taken 5 times in 1 day and then averaging the last 3 of the measures for the most accurate results. Triceps and subscapular skin fold measurements were taken using Lang calipers to the nearest millimeter. Height was measured using a portable stadiometer to the nearest 0.1 centimeter. Weight was measured using a balance scale and rounded to the nearest 0.1 kilogram. Body mass index, or BMI, was gathered using the height and the weight recorded. At baseline and follow-up, a 9-minute run test was performed at both the control and intervention schools to see how the distance differed between the two. The food service changes were analyzed at baseline and during the spring of 4th grade. Trained professionals analyzed the menus and food from 5 days of service, looking at what food was in their kitchens, what was on the menus, and what the serving sizes were. Physical education classes were visited twice per semester for the 6 semesters of the study, and were scored based on the System for Observing Fitness Instruction Time, or SOFIT. Statistical analysis was performed. ANCOVA tests were run for physiological data, the 24-hour recalls, and the 9-minute runs. These tests were controlled for sex, race, location, and had additional covariates, including age, height, and BMI. The HBQ was treated as cross-sectional for this study and was analyzed by school rather than measurement period. The SOFIT analysis was controlled for whether the location was indoors or outdoors, as well as if a specific PE teacher was teaching or a regular classroom teacher. All participating schools maintained the program for the duration of the study. At the beginning, 60.4% of third graders participated in the blood lipid testing, or 5,106 students. 79% of these students were followed through to follow-up. Of those, 90% of the people who remained in the schools were available at follow-up, and only 50% of the people who moved participated in follow-up. A total of 4,019 of the 5,106 students who began the lipid testing were available for follow-up testing. The majority of adults participated in trainings needed to run the program. 86% of the food service workers, 94% of the physical education teachers, and 86% of the classroom teachers attended their respective trainings each year. Over 90% of the food service guidelines were met during the study. Over 80% of the PE guidelines were met, and over 88% of the curriculum was followed. This is due, in part, to the participation of those adults who were running the program in the trainings each year. 70% of families participated, and 63% of families attended the Family Fun Night. There were some non-significant differences at the beginning, as well as some non-significant results at the end. Lucky for us, most of them were included in this study paper. At the beginning, there was no significant difference in risk factors, environment, sex, or ethnicity between control and intervention schools. Following this study, results that were not significant, which did not have a significant difference between the control and intervention students, included daily physical activity reported, height change, weight change, and BMI change, skin fold measurements, and length of the physical education classes, or time they were in class each week. The researchers were also surprised to find no significant difference in the total blood cholesterol or the 9-minute run. This research study did find some significant results that helped us to see how this study could be used further, as well as what differences this study made. There were multiple areas where a significant difference existed. In intervention schools, food service levels of total fat decreased with a p-value of less than 0.001, as well as saturated fat and total calories in school meals with a p-value of less than 0.01. There was a decrease in total fat intake in the students in intervention schools compared to control schools based on the 24-hour recall with a p less than 0.01. There was also an increase in vigorous activity with a p less than 0.003. The researchers also found that the intervention group that had a family component seemed to have a greater positive change, specifically in dietary knowledge. This suggests that including family may be important in future studies.